So why is it so important to identify and treat? So as you guys know, as far as adolescents with anxiety, I'm sorry, here, I skipped ahead. How common first is pediatric anxiety? So it's the most common of the psychiatric disorders in children and adolescents. 7% of children worldwide have an anxiety disorder at any given time. And the estimated life prevalence in the US is about 20 to 30%. So you know, about 1 in 5 or so. The median age of onset is about 11 years old. And each disorder often presents during specific developmental phases. So that can be helpful for us to keep in mind as we're screening from, you know, throughout early childhood through adolescence. So in early childhood or preschool time is when we might see more of the separation anxiety. As we get on into school age years, we see more specific phobias. And then in later school age and early adolescence is when it becomes more of a social anxiety. And then in the more later adolescent, young adult years, it's generalized anxiety, panic, and agoraphobia. So anxiety looks maybe a little different depending on the age often. Let's see. Okay, so why is it so important to identify and treat? Adolescents with anxiety, of those with anxiety, 9% have been shown to have suicidal ideation, with 6% making suicide attempts. So those numbers are definitely concerning and warrant close monitoring. And those with panic disorder and generalized anxiety disorder often have a comorbid depression, and that can convey an even greater risk. So having anxiety increases risk for depression and further increases risk of self-harm or suicide. And then we know that the sequelae of untreated pediatric anxiety disorders are, you know, multi-fold with impairments and outcomes from, you know, childhood to adults, affecting their social life, their education, their occupational, their health, and their mental health. So if we don't address it, it can have pretty serious long-term effects. So how do we assess for it? You know, I'm just kind of sharing what we do in psychiatry, but then also I'll share some scales and suggestions for the primary care setting. We use the DSM-5 as our most updated diagnostic statistical manual. And let's see here, I got some coming in, where we know mental disorders are defined as a syndrome characterized by clinically significant disturbance in an individual's cognition or emotional regulation and behaviors that reflect a dysfunction in the psychological, biological, or developmental processes underlying the mental function. So that's how it's defined there. It's important for us to distinguish this from everyday worries, which are a common part of the human experience. So, you know, we know that it's very normal for us to be startled at times, or for infants to have anxiety when they're exposed to strangers, separation from caregivers and toddlers, for preschoolers to worry about supernatural creatures, or physical well-being and natural disasters might create some anxiety in school-age children. And then, of course, we have more social and existential concerns might show up in adolescence. So those types of worries can be also developmentally within normal limits. So just to kind of review the DSM-5 and the 11 anxiety disorders with 8 subcategories. Separation anxiety disorder, often seen in younger kids, but not developmentally appropriate. We're looking at not like a 15-month-old with separation anxiety, but someone maybe in preschool with excessive worry or distress associated with separating from the primary caregiver or attachment figure. So going to preschool, you know, going with other relatives, being dropped off at an extracurricular activity where it's you know, more excessive than you would expect for that age. Selective mutism is another type of anxiety, the absence of speech, but only in certain social situations, despite the presence of speech in other situations, which usually is at home. There's also specific phobias, which is excessive fear or worry about a specific object or situation. We might see that like around like the dark, storms, needles, high places, where those things feel really unmanageable. And then social anxiety, excessive fear or worry about being negatively evaluated by others in social situations. So I ask a lot of like middle schoolers, high schoolers, like, is eating in the cafeteria something that feels terrifying? Or when you get called on in class or having to like present something in class, or going to a social gathering where you don't know anyone, where it's natural to have some anxiety in those situations, but extreme fear and avoidance is what we would be looking at. And then panic, an abrupt surge of intense fear or discomfort, recurrent unexpected panic attacks, kind of being key here, recurrent and unexpected, with physical and cognitive manifestations. So I just want to make sure I didn't skip anything here. Okay, there we go. And then agoraphobia is the excessive fear or worry about being in situations like crowds and closed spaces where one might feel unable to escape or get help, and panic-like or other overwhelming or embarrassing symptoms can occur. In generalized anxiety disorder, more common in adolescence, excessive uncontrollable worries regarding numerous everyday situations. So usually ask about like, are you anxious about the future, something bad happening, just kind of catastrophizing and having a lot of physical symptoms are associated with this. And then, of course, it's important to screen for substance or medication-induced anxiety or anxiety due to another medical condition. This can occur in the context of substance use, medications, or as a result of physical illness. And then we have always the category of the unspecified type, where they're not meeting full criteria for one type of anxiety disorder. And this is maybe just due to limited information at the time. So things to consider with anxiety, we always want to keep a broad differential and make sure that we're considering things like hyperthyroidism, too much caffeine, especially in our adolescents. I'm always amazed at how much caffeine some of our kids are, what their intake is every day. Migraines, asthma, diabetes, pain, even lead intoxication, hypoglycemic episodes, hypoxia, of course, rare but possible pheochromocytoma, CNS disorders, SLE, as we all know, can present in many different ways. Any kind of allergic reactions, dysmenorrhea, and then medications like especially bronchodilators, nasal decongestants, other sympathomimetics, antihistamines, steroids, especially dietary supplements, stimulants are a big one. Antidepressants can have, that reaction in some people, some antipsychotics, and then of course, a big one in our adolescents, withdrawal from benzodiazepines. So just thinking about the licit and illicit substances, more specifically, this is a really big one. Often, cannabis nowadays, as we all know, the potency is so much higher than it was 10 to 20, 30 years ago. So this is a big one, kids coming into the ER with acute anxiety or paranoia. That's often no longer kind of considered to be a red herring or something, maybe a minor contributing factor, but it could be a major, it could be the only contributing factor here. Of course, cocaine, anabolic steroids, hallucinogens, PCP, or withdrawing from nicotine, alcohol, or even caffeine. And then other environmental etiologies, like, of course, always considering exposure to things like organophosphates or metals like lead or arsenic. And then thinking about other psychiatric disorders that look like or also have some overlap with anxiety, it's broad. And so, just kind of keeping in mind, like anxiety can also sometimes be related to ADHD, in large part because for folks with ADHD, it often is described as feeling like things coming in at the same frequency So something that is important and something that's not important can feel overwhelming and hard to think clearly and organize their thoughts and make decisions, getting distracted easily, all that can create anxiety. With depression too, we see difficulty with concentration, trouble sleeping, physical, somatic complaints that would overlap with anxiety. Also in mania or hypomania, we see extreme distractibility, restlessness, irritability, and insomnia. An OCD type of anxiety, they've taken this out of the anxiety disorders and made it its own specific category. So I'm not going to spend a lot of time on OCD, but really the key thing here, I think, is looking at intrusive thoughts. When people describe having thoughts that come into their head that are very upsetting, whether they're images or thoughts of like, what if I did this terrible thing? Trying to avoid or seek reassurance. I had a patient that had the spiel that she had to do every night, and then she had to seek reassurance from her mom repeatedly. Her mom had to constantly reassure her of whatever it was that she was obsessing about. And so that can be a key part of OCD, seeking reassurance and the intrusive thoughts. Psychotic disorders also can present with restlessness, agitation, withdrawal, distractibility. And then, of course, with autism, we have a higher rate of anxiety disorders, but you might see even more social withdrawal, some social skills deficits that we're already working with, and also, again, distractibility. And then kids with learning issues are likely to present with more anxiety because of the stress that comes with, not being able to, keep up academically, not, feeling that you're falling behind or trouble understanding the way things are being taught. And that can create a lot of anxiety or school avoidance. So important to screen for a broad variety of things in kids presenting with anxiety, or at least things to be thinking about. So yeah, again, depression, ADHD, bipolar, OCD, eating disorders, all of the things here, language disorders, and then these comorbidities can heighten the distress and the functional impairment. A lot of times they have more than just anxiety, and that can, make it harder to treat. And each comorbid disorder can require a separate treatment plan and might influence the selection of treatment for the anxiety disorder. So especially if it's combined with substance abuse, then yeah, we're looking at substance abuse treatment as well as CBT for the anxiety, for example. So just again, in thinking about the medical comorbidities, it could be coincidental, it could be causal, or the result from the physical illness. So the arrows kind of go back and forth, and it's likely to present with a variety of health problems. So kids with anxiety are more likely to present with headaches, stomach aches, exacerbation, maybe an asthma, or trouble breathing, even allergies. So whatever the presumed type of association, each disorder, whether physical or psychological, needs to be separately assessed and treated. So I thought this might be helpful because there's so many psychometric scales out there, and I tend to just rely on the free ones and the quick and easy ones. So I just kind of put my favorite ones for each age group. So for preschool anxiety, these are all available PDFs online for free if you just Google them on various websites. For preschool age, there's the preschool anxiety scale, parent version. And then as you get to the 6 to 18-year-olds, you have a couple of options: the Spence's children's anxiety scale, or my personal favorite, the Scared. Comes in both parent and child versions, really easy to score, helpful for parents to have their input as well, especially if you have kids living in between two parents who are not together. Getting data from both ends is helpful. And then the GAD-7, which is more for 11 to 17-year-olds, great scale. And it's important to remind families when you're doing scales that we might not see agreement between the scales here. And that's to be expected, as anxiety tends to be an internalizing issue. So it's considered one of the internalizing disorders versus externalizing. So families may not pick up on some of the distress because it's happening internally. And so it may not be as obvious. So it's helpful to reassure parents. Sometimes parents filling out scales, we feel like, oh, I should know that. And, I feel badly, I didn't pick up on that. Or they might challenge a kid and be like, that's not happening. And so it's important to provide some reassurance and clarity around that. Mental status exam, it's non-specific to anxiety, may even be absent. They can look really well. But in general, you might see a fastidious or more disheveled appearance in someone who's extremely anxious. Poor eye contact is probably common. Poor engagement or not being very cooperative, a shy demeanor, being more clingy or even tremulous. You might also see the opposite, like fidgety or restless, nervous habits. Somebody might be more hypervigilant, or you might see either poverty of speech or the other end of the spectrum, more pressured speech. Someone might be more perseverative or ruminate and be kind of more fear-laden with thought content. You also might see more distractibility, irritability, and possibly limited insight and judgment. So in formulating anxiety, it's really important to take into account the context. So looking at stressors, also looking at the other end of the spectrum, what is this individual's strengths? What are the environmental supports that we have? And then thinking about cultural, spiritual, gender, and sexual orientation, because all of these things can be used as both consideration of our risk factors, but also our mitigating factors. So when we're getting a history, of course, getting our medical history, developmental history, school, family, social, these are going to be very helpful in thinking about the anxiety. We know about biological vulnerabilities. Family history of anxiety tends to be high in kids with anxiety. And so there's that genetic component, but also there's, the learned behavior component to consider. I always share with families that, it does tend to run in families. We have an inherited vulnerability in brain structure and function. And we can also have acquired insults to the developing brain. So for example, being exposed to domestic violence or, having another head injury or anything that might impact the developing brain could increase the risk of anxiety. We also know some are more prone to autonomic hyperreactivity. Temperament can be characterized by negative affectivity, behavioral inhibition, sleeping and eating irregularities, and then chronic medical conditions can all contribute to being more prone from a biological perspective. Psychological vulnerabilities, also thinking about insecure attachment. So if a child has had a history of growing up with a parent that was suffering from their own mental health issues or substance abuse, or were not present during those early childhood years, there could be a higher risk for anxiety related to their insecure attachment. They can develop more maladaptive thought processes or cognitive schemas, problems like processing information, negative self-evaluation, experience some disconnect between feelings and behaviors, what we describe as ego deficits or problems in internalizing object relations, unconscious conflicts, and then instability of affect management. So not being able to manage their emotions well. So some people are more vulnerable to that, and that would increase their risk of anxiety. And then social vulnerabilities, stressful traumatic life events, a more anxious parenting style, either being super overprotective or over control, and the other end of that, such as neglect. Also, when we see high rejection or criticism, modeling anxious thoughts, like parents who vocalize like catastrophizing, something terrible is going to happen that'll impact a kid. Social skills deficits, peer rejection, inappropriate expectations for achievement, lack of support, for competency development, and then of course socio-demographic or cultural discordance with prevailing norms. So like poor fit in a given environment, adjusting to changes or big moves, like acculturation challenges. So lots of different things would contribute to anxiety, as you can see. So yeah, everything I treat, I always gather information before I decide what the right treatment is, thinking about the clinical formulation from the biological, psychological, and social cultural perspectives. And then within that framework, I'm always looking at the 4 Ps, which are predisposing. What are the biological factors? What's precipitating these symptoms? What are the stressors or contextual events? What's perpetuating it? What are any aspects of the patient that's perpetuating it, the family or the community? And also looking at the positive, the protective factors. So what are the areas of strengths within the individual, the family, and the community? So this helps really frame my treatment so we can address each of the issues that are contributing to the situation. I also spend a lot of time on safety, and I assess this at the first visit and at subsequent visits. Even if the first visit is low risk, I'm constantly screening, kind of given the higher likelihood of self-harm or suicide attempts. So I am looking at suicidal ideation and other risk-taking behaviors, looking at their impulse control, what kinds of high risk or high association with anxiety, and also sometimes with treatment, we see suicidal ideation, which is rare, but something we do need to keep screening for. I'm also frequently screening for trauma because it's so common, but especially in a kid with separation anxiety, asking about it's just exposure to any kind of violence or experience of physical abuse or sexual abuse, any concerns for neglect, any concerns for a parent's safety. All of that often has a high degree association with separation anxiety. And then when I'm thinking about hospitalization, I'm thinking about like somebody who has active intent to harm themselves, more common than others, but screening for that too. Looking at altered mental status, including severe anxiety and agitation. If they've had multiple previous self-harm attempts, I'm going to be having a lower threshold to want to have them in the hospital. If they've been, not responsive to treatment in the past, and if a caregiver is unable to maintain monitoring and safety, that's all going to increase my consideration for hospitalization. So now I'm going to spend some time on treatment because I think that's what everybody is most interested in. Cognitive behavioral therapy is done by myself, and when I'm able to do like add in within each session, but a lot of times I am relying on therapists and psychologists because we're so limited in psychiatry. But there are a lot of people who are trained in CBT. It's very helpful, ages 6 to 18. It's been well established as an effective treatment. It's even used for kids with PTSD, which is not the focus of this talk here, but as young as even age 3. You can tailor CBT for as young as age 3. And what it's doing is illustrating the connections between our thoughts, our feelings, and our behaviors. So it's strategically directed towards eliminating emotional and physical distress, changing the thought distortions, and then alleviating avoidance. And avoidance is the hallmark of anxiety. It's, that's the people's best way of coping with the feeling, but what it does is reinforce the anxiety ultimately. So CBT, challenging thoughts, looking at how accurate the thoughts are, challenging it with a more balanced thought, which ultimately is going to cause one to feel less anxious and then ideally not avoid really stressful situations and take, some of the power away from those situations over time. It does involve often a lot of homework and practice opportunities that reinforce skills to generalize them into other natural environments or situations. It's used often very effective in social anxiety, generalized anxiety, separation anxiety, specific phobia, and panic disorder. And it does require, though, a lot of collaboration with the child or adolescent, the family, the therapist or psychiatrist, oftentimes the school. And usually, if it's done effectively, we can usually see huge improvement within 12 to 20 sessions. So it's generally, it's time intensive, especially with the homework part and engaging families in the school, but it's usually can be pretty effective within 3 to 6 months or so. So yeah, the main interventions are starting with looking at thought distortions and reducing avoidance, and also helping to manage that arousal and somatic symptoms. So a lot of the elements include a lot of education about anxiety. So it's really helpful actually for kids to know how common anxiety is. Just enough with like basic psychoed, just talking about how many kids probably in their class have anxiety, what anxiety can feel like in your body. Have them set some behavioral goal setting with contingent rewards, like if they would like to be able to go to a sleepover, and they're working towards, being able to do that by working, with their therapist on CBT techniques. Helping them self-monitor for connections between their worries, fears, thoughts, and behaviors. Also, a large part is focused on relaxation techniques, such as belly breathing. We do different things like 4 square breathing, where it's 4 on the inhale, then pause for 4, 4 on the exhale, pause for 4. There are many different ways to teach relaxation techniques, progressive muscle relaxation, guided imagery. So depending on what sticks, we have lots of options on that. And then a big part is the cognitive restructuring that challenges those distortions, overgeneralizing, negative predictions, all or none thinking. So helping them kind of first identify what they tend to be using is what's creating the anxiety, what type of thinking. And then graduated exposure, starting with something small and over time working towards the ultimate goal to a feared stimulus. Problem solving skills are also a big one to anxiogenic situations. So what are we going to do when we get to the doctor and we have to have shots? We're kind of planning ahead and how we're going to manage, some of these feelings that come up. A lot of family directed interventions are going to be really, really important. Often, family and their, they have the right intention, but often their approach to a child with anxiety is to alleviate their anxiety by doing for them. And, sharing like, oh, my kid really doesn't like, doing this or that. So can we not do this or that? I hear that often. And the kid actually probably is somewhat anxious, but the message they're getting from the family is it is too scary to do this. And so helping parents to also reframe, how they're going to address some of these fears with the kids is going to be, really important. Reducing their own anxiety and fostering anxiety reducing parenting skills is a big part of the treatment. So I want to spend some time on the SSRIs because this is probably your go-to. This is the one that, is probably the most established empirical data. It is being, offered, although I've used it occasionally in younger kids with severe symptoms, but rarely, ages 16 to 18-year-olds with moderate to severe social anxiety, generalized separation and panic. As we know, serotonin function is thought to play a role in the ability of the brain to modulate fear. and facilitate cognitive processing. SSRIs inhibit the presynaptic reuptake in the brain and thereby increasing serotonin in the synaptic cleft. And it can also lead to the downregulation of inhibitory serotonin autoreceptors, and that eventually heightens the serotonergic neuronal firing rate and increasing serotonin release. So because it seems like it's a multi-step process, that's why we think there's probably a delay in the onset of the effects. It takes time for the downregulation of autoreceptors. And so often we don't see its full effects till about 4 to 8 weeks from the time they get to a therapeutic dose. So the ones that we tend to use, I'll just share, I tend to use escitalopram or Lexapro, and sertraline by far most common, and fluoxetine maybe next most common, and rarely paroxetine, occasionally fluvoxamine for OCD, rarely citalopram because escitalopram seems to be more effective and more insurances are covering it. And I don't think I've ever used vilazodone, but these are the ones that are listed. And it's interesting, there's substantial empirical data for these medicines, but there's no specific FDA approval for the indication for anxiety. There is for depression, but I'm unclear as to why it hasn't achieved full FDA approval. So, however, they are used, and there's a lot of empirical safety data. So the choice of SSRIs is usually governed by considerations like pharmacokinetics, the dynamics, tolerability, cost, what formularies are available, and the unique risks to leading to warnings or precautions. So just like as a cheat sheet, fluoxetine and sertraline, probably pretty similar first line options. I tend to go with fluoxetine if a kid has the type of anxiety that's more low energy, withdrawing, kind of a more avoidant and not the agitated type, because fluoxetine can be activating. So it tends to be more for depression, withdrawal type of contributing anxiety versus sertraline, which tends to make most folks a little more sleepy. So we take it at night. It tends to be, pretty well tolerated. You can take it with other medicines pretty safely. And has a lot of data also. I often these days have been doing escitalopram or Lexapro as a first line because I've seen it work so quickly, like within a couple of weeks for a lot of kids. And most insurance have been covering it. So if I'm feeling like there's some urgency and we need to get more of a response quicker, I tend to rely on Lexapro. However, if a parent says I've been on sertraline for anxiety, it's worked great, I'm definitely going with sertraline. The only time I might use paroxetine is if I have a parent or sibling that tried multiple meds and paroxetine was the only thing that worked, then I'll go with paroxetine. But generally speaking, paroxetine has a lot of side effects and is not ideal as far as discontinuation syndrome also. So I try to avoid it unless there's good reason for it. A note on pharmacogenomic testing. A lot of families have been coming and asking like, hey, can we get this, the cheek swab and find out what medicines work and don't work? Unfortunately, there's not strong evidence yet for it. It gives you a very mixed bag report. I found it to be not helpful at all. They have a green column, yellow and red, and medicines that were in the red column they're supposed to avoid. And sometimes I've seen only medicines in the red column actually be helpful. So I don't think we have, we're not there yet in terms of, the usefulness of this tool. Hopefully in the near future. So as far as the pharmacokinetics and dynamics, there's limited data for SSRIs for young people. But what we do know is that a lot of them have a long half-life, especially fluoxetine. So usually it's a once a day dosing. Sometimes for sertraline and fluvoxamine, we need to do twice, but mostly I'm doing once a day dosing. As a group, SSRIs are generally well tolerated. Usually, I always say this, I always tell families that the side effects, some people experience none. For those that do, most people note that they go away within the first 2 to 3 weeks. And if we don't tell them that, they're likely to just stop it and never come back. So I make a point of really, you know, expressing that, you know, you're likely to start feeling better at the same time that the side effects are going to go away. So if we can tolerate it, you know, we can do things like Tums, Tylenol, Motrin, but sometimes dry mouth, nausea, diarrhea, heartburn, headaches, somnolence, insomnia, dizziness, vivid dreams, changes in appetite, weight loss or gain, fatigue, tremors, bruxism, diaphoresis. And then, of course, you know, we have to think about the more serious side effects, suicidal thinking, activation, mania or hypomania, sexual dysfunction, seizures, abnormal bleeding, and serotonin syndrome. So usually I'm just kind of like saying it's possible, but also it's possible on most any medicine that we take, and therefore let's monitor closely. But generally speaking, the more mild ones are going to dissipate with it within a few weeks. I do touch on the black box warning every time, but I try to emphasize how the risk is overall pretty low in terms of suicidal ideation. There's been lots of studies looking at this. Even though there is a warning up until age 24, there's a lot of data to show that the risk of untreated depression or anxiety is actually much, much higher for suicide compared to being on an SSRI. So the biggest studies looked at or found that 1% for youth treated with an antidepressant experienced suicidal ideation, and 0.2 treated with a placebo experienced SI. This yields a number needed to harm of 143 and a number needed to treat of 3. So generally low risk, but I always am saying, hey, let's follow up every 2 weeks, 4 weeks in the beginning, and any new or persistent thoughts of suicide, to call and make sure they have access to hotlines and support. And so although the margin of safety for SSRIs and overdose is greater than for other antidepressants, we also have to be thinking about, in overdose, deaths have been reported with very large ingestions. So when you're working with kids and adolescents, though, I'm always asking parents to administer and monitor. The mere fact that we're treating their anxiety and depression with meds means that it needs to be closely monitored. So activation is something that we have to monitor for also, so that restlessness, insomnia, impulsiveness, talkativeness, disinhibition, aggression, more common in younger children especially, more common in those with anxiety versus depression. Usually you see it early on when you start the SSRI or when you increase the dose, or if you're taking a new medicine that might inhibit the metabolism. So that's why we do a slow up titration and close monitoring, especially for younger kids, and educate parents in advance about the potential for this side effect. And that's, going to be on the more, lower risk end of the spectrum. The higher risk end would be the mania or hypomania, which is rare, but if there's a family history of bipolar, it's not so rare. We need to be aware of that risk and distinguish that from behavioral activation. So activation, usually you see early on. Behavioral activation usually improves when the dose is decreased or stopped, and mania might persist and require more active pharmacological intervention or hospitalization. So the big thing, I think, is when you're starting any kid on an SSRI, asking about any relatives with bipolar that will increase our need to monitor for mania. There's also things to consider. Sexual dysfunction, is that going to also impact one's adherence to the medication? Seizures, which could lower the threshold, abnormal bleeding, especially with the use of NSAIDs. We might see more echinosis, hematoma, DPI, epistaxis. Serotonin syndrome, I think I've seen maybe twice in the last 12 to 15 years since residency. It's caused by elevated serotonin levels, usually when we're combining medicines, usually within 24 to 48 hours of combining them. You see mental status changes, neuromuscular hyperactivity, tremors, clonus, autonomic hyperactivity, hypertension, tachycardia, arrhythmias, and in more advanced symptoms requiring hospitalization, fever, seizures, arrhythmias, loss of consciousness, which can be life-threatening. So although rare, something to always be mindful of. As I mentioned earlier, each SSRI has its own consideration. Fluvoxamine has a lot of drug-drug interactions. Paroxetine can have a lot of problems with discontinuation, especially citalopram can cause QT prolongation associated with Torsades and VTAC. So paroxetine was also shown to have the most increased risk of suicidal ideation. So again, I kind of only use those if there is a strong response in a first degree family relative, because there is some more risk with those ones. So monitoring, we want to monitor vitals. If they are stable, I usually do every 3 months. There's no specific labs unless we're screening for other medical factors that would be contributing to the anxiety. Once remission is achieved, I usually suggest we stay on the medicine. Well, the guidelines suggest that we stay on it for at least 1 year. It used to be 6 to 9 months, but now we know that we need to stay on the same dose, continue therapy for 1 year after remission is achieved. So I usually say start the timer once we've hit remission, not when we take our first pill, but once we've reached remission. And then we monitor, and then we try to, if we are going to discontinue, we do that during a relatively low stress time like summer. Some kids with severe and chronic anxiety may require lengthier treatments, and I emphasize that this is safe and also is not going to create dependency, is not addictive, and the risk of keeping anxiety in remission is much more beneficial than the risk of or side effects of the SSRIs. Determinants of non-adhering, and this is, we all know that there's multiple factors that contribute to people not taking their medicines. We use a lot of strategies, sometimes very concrete, educational, integrating, and liaison with all the providers. Sometimes just pill boxes, parental oversight, but really trying to emphasize the importance of taking it consistently. Discontinuation syndrome, most common in paroxetine, the least common with fluoxetine because of the long half-life, but basically it's like flu-like symptoms. People feel kind of junk, and it's important for them to be aware of that, so they don't stop entirely, but we can come up with a way to take it consistently. Switching SSRIs, there's no definitive empirical guidance, but usually I try to cross taper, go slowly down on one while starting the low one, another one at a low dose, so that we don't have an exacerbation of the original symptoms of what we're treating. And usually that's just done slowly. So just want to spend a few minutes on the SNRIs. This is the serotonin norepinephrine reuptake inhibitors, also offered to kids age 6 to 18 with a variety of anxiety disorders. As is in the name, this one inhibits the reuptake of both norepi and serotonin. And, as a stress response that includes alertness, arousal, attentiveness, and vigilance, that's all modulated by noradrenergic neurons, if we think back to early med school days. And it's interesting because although associated with the stress response or the fight or flight and the generation of fear and anxiety, paradoxically, noradrenergic medications have been shown to empirically be effective in the treatment of anxiety, possibly because of the complex interactions with other neurotransmitters like serotonin. So these medicines include...
I'm sorry to interrupt. I just wanted to let you know we've got about 9 more minutes.
Perfect. Okay. These SNRIs all included here. Quick note, atomoxetine is not effective for anxiety as a primary disorder. Atomoxetine is Strattera. It's been approved for anxiety and ADHD, but not been shown to be helpful for just anxiety alone, and really only mildly helpful for anxiety and ADHD. So I tend to shy away from it. Duloxetine is the only SNRI to recently gain FDA indication for treatment of anxiety disorders in kids 7 to 17. So I've been using it a bit more and having some positive responses. Monitoring for very similar side effects as the SSRIs, venlafaxine of note, greater suicide risk, greater overdose fatalities, and greater discontinuation symptoms. So again, monitoring is important. Duloxetine, we see a higher risk of hepatic failure, hepatomegaly, higher risk of erythema multiforme, SJS, transaminase levels bumping up. So I haven't ever seen that, but it's important to be mindful of. And as with the other SSRIs, discontinuation syndrome is something we need to monitor especially. So just in wrapping things up, I want to emphasize the importance. The empirical data really shows that when you combine CBT plus SSRIs, we show that it's not only safe and effective, but not just in the short term, but probably also in the long term. It's the combination that's much, much more effective. SNRIs have some empirical support as an additional treatment option. CBT is always first line for mild to moderate symptoms. And then we combine CBT plus SSRI or SNRI for the moderate to severe symptoms. In combination, it's much more effective than one by itself. And then because effective treatment outcomes are predicted in part upon accuracy of diagnosis, the depth of the clinical formulation, the breadth of the plan, using a comprehensive evidence-based assessment will enhance the treatment. So these are just some references and resources that are free too. This is a great website, the acap.org has printouts for families, facts for families that you can print out. Also has the updated practice parameters that I summarized here. And then screening tools. These are like workbooks that they can actually print out and families can work on with their therapists that are super helpful. I used to have to buy all of this in residency and now it's free online, which is great.